expression what we can expect from our current practice in near future. I want to share some of my opinions to you, and I really welcome all of your opinions or comments on that. Actually, this is the time for non-communicable diseases because all the global mortality is mostly from non-communicable diseases, and it is still growing. So our target should be non-communicable disease now, and it is not only for developed countries, not only for the developing countries. It is all of them. So if you see here, so cardiovascular diseases and cancers are in all over the world. So I want to emphasize that non-communicable diseases are all over the world, and it should be our target. And so we have a common problem of so as the television becomes thinner, we have become thicker. It is our common problem. And the four typical non-communicable chronic diseases, we share the risk factors: tobacco use, unhealthy diets, physical inactivity, and harmful use of alcohol. So we can do something. 65% of global deaths are due to non-communicable disease, and it is still increasing. Majority of the burden is now low and middle income countries. Up to 80% of cardiovascular disease, stroke, diabetes is preventable, 40% of cancer preventable, and cost-effective interventions are available. But we are kind of imagists. Of course, we have a radiation oncologist here, but our primary concern is images. But in the United States, medical imaging is a little decreasing, especially for myocardial perfusion imaging. We are experiencing a kind of a decrease. In my country, it is also a little plateau and a little decreasing here. So we are expecting a further decrease from now on. But it is not in the case in all countries. For example, in Japan, the myocardial perfusion imaging is still stable, and cardiac PET is increasing, but it is still very limited number, only 1.8% of MPI in Japan. So I surveyed throughout Asia this last February. If you see here, the I means increasing nuclear cardiologists. S means stable. Decreasing is only in Korea and Beijing. So some institutions in Beijing. So as a whole, I think we don't have a very challenging situation. It is still so very active in this region. Okay. If I mention about this kind of consensus, this is the appropriate use criteria recommendation worked by many specialists from cardiologists, cardiac surgeons, so radiologists, and nuclear medicine people. So from this experience, we learned that communication with the referrers become more and more important for our future or for our success. If I briefly introduce some of recommendations from this consensus, in stable angina with intermediate to high pretest probability or even low probability when the ECG is not interpretable, they strongly recommend nuclear cardiology studies as well as stress echoes, but not recommended CT coronary angiography. So this kind of consensus is very important for us for our activities. For example, this patient is a 56-year-old male with atypical angina. He had diabetes and hypertension. If we refer to this table, this patient has intermediate probability, so it is a candidate for nuclear cardiology studies. But we cannot see any abnormality from this study. So we recommended medical therapy and coronary angiography deferred, and for several years there is no event at all. So that is what we should do in our current practice. But things are changing in cardiology because the interventional cardiologists prefer to use FFR. It's a fractional flow reserve, what means the ratio of distal pressure to proximal pressure. And from the many landmark trials, Courage trial showed anatomy-guided PCI has no prognostic gain. FAME trial showed FFR-guided PCI is better than anatomy-guided PCI. FAME2 showed PCI is better than medical therapy when FFR is less than or 0.8. In deferred trial, PCI can be safely deferred when FFR is 0.75 or over. So this kind of functional, physiology-based intervention is meaningful. But they say it is very new. But we say it is not new because we already knew from our long practice of nuclear cardiology, cardiac perfusion imaging. We already know that if more than 20% of heart is ischemic, and if you do medication without surgery, you have 3 times higher chance to die. We already knew. And again, if there is no ischemia, if you do surgery, you have 9 times higher chance to die. We already know that. So we have a 10% rule. If the ischemia is more than 10% of left ventricle, you go to surgery. It's less than 10%, you go medication. It's this kind of evidence we have. So that is our strength. But we have a better machine nowadays, better tool. It's a PET-CT. It's a better image quality, faster image acquisition, lower radiation dose, less artifact, and we can measure blood flow and flow reserve, and also we can provide anatomic information. So for example, in this case, we measured CFR and FFR using this kind of three-dimensional fusion. This is a very focal calcified plaque. So CFR was normal, but FFR is low. But in this case of diffuse disease, CFR is low, FFR is normal. Then how can we do? We can recommend many strategies. For example, in this paper, it's a JACC cardiovascular imaging paper. This is a kind of comprehensive explanation of the cardiac coronary physiology. If FFR is high and CFR is low, it is predominantly microvascular disease. And FFR is low, CFR is normal, then it is predominantly focal disease. So we can decide how to manage our patient. So nuclear cardiology studies, we have many indications now, and we have new tools and a new SPECT machine, cardiac dedicated machines. So we have many things to do for cardiology. Let's go to oncology. It is in most countries, if you do PET-CT, especially FDG PET-CT, so almost more than 90% are for oncology. And for oncology, we do staging or restaging or response monitoring using this PET-CT. For example, so you see 3 cases of lung cancer. This is just one side lung cancer, the stage maybe 1 or 2A. So it is spread to regional lymph nodes, and it's spread throughout the body. So we can select appropriate treatments from, so we can recommend surgery for this patient, surgery plus radiation, or CCRT combined chemoradiotherapy, or it's only chemotherapy for this patient. So this kind of guidance of treatment can be possible by using nuclear medicine technologies. And in 1/3 of PET-CT finds unexpected metastasis from our experience, and more than 40% chances therapy plan changes after PET-CT. So it becomes a kind of standard procedure in oncology. So we have this kind of exponential growth in many countries which adopt these technologies. But we can expect another chance of change in near future. Last year, President Obama explained the precision medicine initiative in press release. It means genetics come to the practice. It is an emerging approach for disease prevention and treatment that takes into account people's individual variation in genes, environment, and lifestyle. So it generates a scientific evidence need to move the concept of precision medicine into clinical practice. That is clinical trials for targeted drugs for adult and pediatric cancers. So for oncology first, and use of combination therapies and knowledge to overcome drug resistance. This strategy rapidly adopted by other countries, like China. President Xi announced by just the next month, and Prime Minister Abe, and also in my country, President Park adopted this concept very rapidly. So now we have a new concept of medicine, is a precision medicine. Then what we should do for precision medicine? That is now good question, because the paradigm shifted. We have we want to understand the disease mechanisms more and more, and we try to subgroup in one diseases. For example, in lung cancer, previously we divide the lung cancer adeno-CA, large squamous cell CA, large cell CA. But these days, we put KRAS, EGFR mutations. Nowadays, we have more and more gene mutations. And it becomes the guidance of treatment. If there is a mutation, we select different target agents. So what we should do for this? For example, so if we use this crizotinib, if there is a mutation, it works for those patients with ARC mutation, but if there is no mutation, it doesn't work. So now, I think we should work for that. We should do something for, try to find some findings or some traces to subgrouping of our patients. So, for example, in my lab, we are doing, we are trying to find some phenotypes come from genotypes. So those things we should do in near future, I think. And in breast cancer, we are doing, if estrogen receptor imaging is possible in many institutions. Okay, let's move to brain. We have many diseases. So neurological examinations are not common in many institutions so far, but we expect to have a kind of another explosion of application of nuclear medicine in brain, because we have many diseases like dementia, cerebrovascular disease, and others. Let me introduce just some of applications. For example, this is a 73-year-old male with memory impairment, and it progressed gradually, but the MRI was normal. But in FDG PET, we can find some discrete decrease of metabolism in left temporal area. So our diagnosis was MCI. It's a minimal cognitive impairment, but it's slowly progressed. This is a functional study of dementia, neurological study. It goes slowly going down, and this score slowly going on. So in this case, FDG brain PET is more sensitive than MRI. So this kind of applications are coming more and more. So for FDG PET is in my institution, it is using for early diagnosis and differential diagnosis of dementing disorders, and sometimes monitoring of patients. And we have another tool nowadays. This is amyloid imaging. So if there is amyloid imaging, there's a more chance to be diagnosed as Alzheimer's disease. But it is not all. We have to evaluate by various methods. For example, this is the stage of dementia. It's a preclinical MCI and fully expressed, fully developed dementia. And amyloid accumulation is very, very early stage. So it is very sensitive, but not so specific. FDG and functional MRI follows, and structural changes follows later. So if we use the amyloid imaging and FDG imaging and MRI or CT, we can categorize our dementia patients. So I think this is our near future practice. And dementia with Lewy body or Lewy body, so DLB is another disease for dementia, making dementia. But we have a good way to differentiate them. So this is Alzheimer's disease. This is Lewy body disease. If the occipital region is involved, this is DLB. It is spared. If it is spared, we say it's Alzheimer's disease. But why we should differentiate? Because in most cases of DLB are erroneously mislabeled as Alzheimer's disease, which can have major negative consequences for patients. For example, neuroleptic drugs, commonly used for psychiatric symptoms and behavioral disturbance in dementia, can induce severe sensitivity reactions in DLB patients, exacerbating motor and mental instability and leading to 2 to 3-fold increase in mortality. So this kind of differentiation is very, very important in dementia patients. And that should be our practice. We have many other applications in cerebrovascular tract. So I expect more and more application of nuclear medicine practice in neurology now. For therapy, so again our future. For example, in Japan, Japanese government now decided to reduce their research budget to molecular imaging. They decide to shift that money to therapy, nuclear medicine therapy, I mean. So I expect to hear some more news, positive news from Japan from now on, from next year, because they want to use more budget for therapy. In Korea, we experienced this kind of exponential growth of nuclear medicine therapy. So our new field should be theranostics It means we do use the same target for both imaging and therapy. It will be we learn from Professor Homer for these theranostics. So it is very much interested in many nuclear medicine doctors in this region. So my next comment comes to the availability of our technology throughout our region. WHO reported a couple of years ago for the universal health coverage. It means that everyone should have access to the health services they need without risk of financial ruin or impoverishment. It is a good word, but it is not true in most of our region. But we should do something for this, I think. For example, for PET-CT and cyclotron, we surveyed the availability of PET-CT and cyclotron in Asia, in 1,369 hospitals in 112 countries. It is not only in Asia, in the world, but mostly our colleagues, they do not have PET or cyclotron. So if we count the number of PET-CTs per million, it's 4 million in United States and South Korea, 2 and 3 in Kuwait, Japan, so many European countries. But in large countries like China and India, it's still very lacking. But the good news is I learned from my friend, as the current president of Chinese Society of Nuclear Medicine, so Professor Yaming Ni. He told me that China decided to put this nuclear medicine, especially PET-CT technology, to every region in China. They have more than 3,000 provinces. That means 3,000 PET-CTs. Now they have 200. So, Dr. Lin, so it's around 200 PET-CTs now in China, so 250. But it becomes 30,000 very soon. The target is less than 10 years, they say. So it's a kind of, again, another explosion there. And again, another good news is from Vietnam. They decided to put nuclear medicine and radiation oncology in each provinces. It is, we don't have one from Vietnam this time. They have 60 or 70 provinces, so they may have, again, we can expect good news from Vietnam too. So that is a governmental decision. You are not prime ministers, you are not presidents, so you cannot do that, but that strategy comes from nuclear medicine. Nuclear medicine experts persuaded their politicians, their leaders. So from now on, let's do that. Let's do something for our countries. If you have any chance to meet some minister or politicians or prime minister, you can explain what the China do, what the Vietnam do, and what other countries do. Then after that, we have many things to do. Okay, so this is Charles Darwin, who observed the finches in Galapagos, and he found all the finches develop differently in many islands. What I want to say is we are very different in each country. The nuclear medicine practice is very different. For example, in Vietnam, in some institutions, this is the largest hospital in Vietnam, they do both nuclear medicine and radiation oncology in one department. And in Bangladesh, they do nuclear medicine and ultrasound together in one department. In some institutions, this is the National Heart Institute in Singapore, so nuclear cardiologists mainly do nuclear cardiology there. So we have quite different practices. But this is my the second last slide. In 1994, more than 20 years ago, Professor Henry Wagner mentioned nuclear medicine. What is nuclear medicine tomorrow? In nuclear medicine today, it has never been more important to develop a strong, highly expert cadre for full-time nuclear medicine physicians and scientists. But we should go to molecular nuclear medicine, and nuclear medicine should be the stem of all medicine. It is a very grand dream, but so we are in the era of precision medicine. I believe, nuclear medicine becomes more and more important, and we have more and more larger roles in medicine. But my last slide goes to this kind of education and training. What we should do in this region to work together. So at the lunchtime, I told Professor Hamda Saleh, we are so different. The standardization is one of our roles to do, our responsibility. But Hamda told me, difference is better because all the same things is saying the same words is boring, of course. But I'd like to repeat her last word, is doing together. So working together with different ideas, different tools, different systems makes our people happier. So thank you very much for your attention.